Hi guys, it's Annie McDonald, physio and strength and conditioning coach, and welcome to the Informed Performance podcast. It's been a long time, but we are now back in business. On behalf of myself, Ben and Alistair at Informed Performance, we apologise for the break in episodes. All of us have enjoyed some recent work changes over the last few months, and unfortunately that meant a pause in our content delivery. But we have all settled down professionally again, and most importantly, we are back in our flow recording and releasing conversations with the high caliber professionals that we persuade to come on the show as guests. So again, we are sorry for the intermission, and we hope you'll be tuning in regularly once again to the Informed Performance podcast. All of us are very excited to be back having these conversations and to be able to share them with you on our platform. To kick off, Ben will be hosting today, so I'll hand over to him in just a second. I hope you enjoy. Today's episode of the Informed Performance podcast has been sponsored by Vald Performance, makers of the Nordboard. The Nordboard has become the gold standard for assessing field-based hamstring strength. By combining advanced sensors, real-time data visualizations, and cloud analytics, the Nordboard helps practitioners to accurately measure, monitor, and train individuals' hamstring strength or imbalances. To learn more about the Nordboard, visit our sponsor, valdperformance.com.
Welcome to another edition of Informed Performance Podcast. My name is Ben Ashworth. Today is a special athletic shoulder episode looking at research unpacked. We're going to be talking with the group who put together the shoulder consensus paper. Now, this was over a year ago now, and actually the episode was recorded a long time ago, but due to the way the world is and how things have gone recently, it's taken a long time to get this out there. So apologies to Ariane and Paul, who waited so long for this. And I'm just happy enough to be able to get it out there and share with you some of the findings from their research. On the show, we've got Ariane and Paul. So welcome to the show, both of you.
Thank you.
Ben.
Hi, Ben.
So we're going to be talking about this consensus paper. So Research Unplugged is going to be looking into this Bern consensus statement on shoulder injury prevention, rehabilitation and return to sport for athletes at all participation levels. But before we dig into that, let's get a flavour of the backgrounds of these two guys who are responsible for the paper. So if we start with you, Ariane, if you can give the listeners a little bit of background as to what you do and where you come from and how you got involved in this paper.
Yeah, thank you. First, again, to host me and having me here. This is my first podcast. I'm from Zurich. I'm a clinician physiotherapist at Canton Hospital in Winterthur, which is close to the city of Zurich. And I'm a clinical shoulder specialist. I've been working predominantly with shoulder and elbows for 6 years now. And I started my PhD with the topic on shoulder pain, especially in rotator cuff patients and rotator cuff related shoulder pain in 2018 at the University of Antwerp. And I got involved in this project by Claire Ardern, the last author. And when she called me and asked me to participate together with Paul, there was a no-brainer for me. A huge, chance to progress my research knowledge and skills, and also to deepen relations and all the very exciting knowledge about the shoulder and shoulder experts around the world. So, perfect. Here we are.
Yeah, it's great to have you on the show. We've met before, obviously, and unfortunately couldn't get out to see you in Switzerland, but I hope we'll manage to put that in place in the future. Paul, same question, really. Just a little bit about your background, please.
Yeah, so I'm also a physio. I qualified in the UK in London in 2008. Worked primarily in the health service, NHS, and then a bit in sport for 7 or 8 years. A little bit mostly in football, actually. soccer for our American friends. And then took a role in doing some education stuff just before I moved out to Canada in 2017. So did a PGC in healthcare ed as well. When I got out here, started working for Professor Karam Khan, who most listeners I hope would know, was the editor for Clinical Sports Medicine Edition 5, Volume 2. And then got moved over onto BJSM as well. So started working as an associate editor. So this isn't my first podcast, but I'm normally on the other side of the mic. And then happened to meet Claire through Karam and started work for JOSPT, which led to me being involved in the consensus work. Still work clinically, and actually since undertaking this have taken more of a keen interest in the actual methodology around consensus development as well. So this actually taught me some lessons around things I might not do if we were to do it all again. So it was interesting, like doing this for sure.
That's it must be a pretty daunting task to try and pull all of this together. It's certainly not easy. Just before we start to sort of get into the content, have you got any advice, either of you, for people who are considering something similar in other areas? Perhaps maybe things like you say, Paul, that you might have done differently.
I've got quite a bit. So I actually ended up writing a consensus editorial that was published in BJSM about 6 months ago, and has gone pretty well. And that had some lessons in there that sort of were around just making sure that you're really clear on the questions that you want to ask. So I actually think the number of questions we asked on reflection may have been a few too many, which in a way was good because we got a ton of information. But then when you're trying to drill that down, it's then a bit harder. So I think I would have been a bit more specific at the start, and that's always hard when you're trying to get a general consensus on return to sport for all shoulder conditions across all sports. But the other thing is like around stakeholder engagement. I think we actually did a good job of that in this because we involved a really wide range of people, and we were quite conscious to try and get different professions, to get different people from different parts of the world. So the US and Europe, where there is a bit of a split in terms of the way people manage shoulders. And we wanted to capture that difference and then discuss it. But yeah, they're just a couple of the main points. But if people want to know a bit more, then I'd definitely encourage them to go have a look at the editorial and see what they think, because there was some lessons in there that I think people can use if they're trying to get consensus on a topic in the future.
And Ariane, anything that you'd perhaps might have done differently?
I think one of the challenges is also to get people like the co-authors, coordinate the co-authors well. You may lose a lot of time if you haven't prepared them thoroughly in advance. Like when we sent out our summaries from the discussion, we lost a bit of time because everyone has his own and her own schedule as well. So you really have to prepare well time-wise. When do we want things back? And of course, we did set out deadlines, but each individual has his and her rhythm. So I think that's very important as well. When you meet each other at the main consensus meeting, then you can try to set up a good timetable already, and then go back to that what you have discussed there. But essentially, I also think is the core team that Paul, Claire, and I, we were keeping our motivation throughout the whole process very high, and we were super fast in responding, and I think that's also, you really need to be committed to this project to be able to finish it within a reasonable time. And I think that's one of the major powers that you need to have, or just to really finish it off as well.
I had a chat with Christian Barton just before Christmas, and he's done a few consensus projects as well, and he said it's a bit like herding cats sometimes, and you're trying to keep everyone together, and it's it's not that easy to try and get that project like through, and it does take time. And I think that's the other thing is people shouldn't expect everything to happen quickly. You know, it is something that you do have to plan. You can't just get everyone in a room and say, well, what do you all think? And then we're going to publish this. It is, there's a process that you have to go through, like any research project. And you do have to really think about it beforehand. You can't just show up on the day and say, hey guys, you know, we're going to vote on what the best things are. You know, if you want to get a good answer, you need to put the preparation in first.
So yeah, herding busy cats. One of my friends said the other day. I think that's a really nice way of summarising it. Okay, let's crack into the paper itself. And firstly, before we start, I'd just like to say, you know, someone who's passionate about shoulders themselves, I found it was really well written and put together, and the way it's structured and the way it's ordered with the themes that you use was fantastic. Let's start by just, for the listeners, explaining a little bit about the Delphi process itself before we go into the content itself.
So we started off with getting into research and filtering information from other consensus statements and systematic reviews and randomized controlled trials. And we is Paul, Claire, and I started formulating potential questions and statements that we put together as questions to then spread in the shoulder expert community around the globe. And there we really try to balance, as Paul said before, male and female, as well as we try to get in all the continents. And then we had this first round of Delphi, a study that was an online questionnaire with different sections, but not only the 4 sections. We also had included rotator cuff rehabilitation or a specific diagnosis like instability. Also, we had included the scapula as a known topic. And then after the Delphi round 1, we got 42 respondents out of 44 the questionnaires, and then spread questionnaires. And then we synthesized everything. We we filtered all the points that were not where no consensus was found, so not a disagreement nor a consensus. And then we formulated new questions. They were more into like ranking questions or yes or no questions. And then we set up a second Delphi round and sent it out to the same individuals again. And then after the Delphi round 2, we synthesized everything, Paul and I, and created overviews for the 4 topics that should be discussed at the Delphi, at the in-person meeting in Bern in November. And so we then also decided we set up teams of 2 from the experts that were invited as guest speakers for the Athletic Shoulder Symposium in Bern, and they prepared the presentations to then discuss as a whole group, point by point.
Yeah. I just wanted to add as well to that when we were doing the literature searches, we specifically try to focus on areas where there was no agreement already, because one of the things we see a lot of is people kind of just come and they agree on things that we already know, and we knew that wasn't going to add any value to the clinical community. So we were like, right, well, we want to find what we don't know. So when we're going to get all these people together, we're actually going to come out with something that's useful at the end of it. And I would say when we search the literature, you'd be amazed at how little there actually is out there on return to sport after shoulder injury. That's bottom line. Like, there needs to be more specific studies in this area for us to have really well-informed opinions. But we were looking for those areas where there was like disagreement almost. And that was after the process that Ariane just outlined really well. That was the thing that we then took to that in-person meeting, was like, okay, well, where are these areas of the biggest disagreement, and how can we help people in practice to like move forwards when they don't know what to do, and where the experts are sort of telling them different things, or the research is telling us different things.
So when I read the paper as well, I found it really useful that you broke it into kind of 4 sections eventually. And obviously you've already told us that, you know, some things were left out. We'll probably come on to those a bit later, because I'm quite interested in that. But let's go straight in, and I'm going to ask some questions based around some of the content. Section 1 was basically titled "Prevention is Better Than Cure." I love that wording, that phrasing. And one of the things that came out of that was that there's a suggestion that there's a place for a generic musculoskeletal screen. But what wasn't agreed on was the kind of frequency of how often this should be performed. So I want to know a little bit about the discussions you had in the group, and where was the group leaning towards in terms of the frequency of this kind of musculoskeletal shoulder screen?
Well, yet the discussion was really also about screening versus monitoring, because do you screen for something that you want to see? The major discussion was about screening for scapular dyskinesis. That's where it all started. And there, for example, we know if you screen for it, you already have it in your mind, and the scapular dyskinesis is predominantly diagnosed by your observation. So if you look for it, you will also see it. And that's one problem with scapular dyskinesis, for example, besides that it is very present in overhead sports and maybe a natural, normal adaptation to the demand. But if we talk about monitoring an athlete through the season, it is also, we had a lot of discussion that it is important to have it pre-season, to have a reference for if there is any injury that you can refer to your intra-individual. So you have your pre-season, potentially mid-season, and then post-season measurements, but it is also dependent really on your risk factors, like if you have low strength or decreased rotational range of motion in one athlete, you might be more prone to screen this person more often throughout the season. And depending on the load demands, then also you might screen that person or monitor that person more often. And that's also our paper really stepped back from providing too many suggestions for one case, but we tried to get little bit into practice in the 4th section where we have the case examples. But as for the risk management section, we really try to point out that it is very important to of course have a bit of a red line with your parameters, that's like strength measures, range of motion measures, load measures, but there is no clear suggestions from our side when exactly you have to screen or measure them.
Yeah, and the reason for that was, we said, due to the heterogeneity of conditions and sports, it would be hard to give a one-size-fits-all number as to how often you should do it. So, and just to go back a bit as well, when we talked about prevention, there was a bit of discussion around, well, why are we talking about prevention when we're talking about a return to sport where, so there's already been an injury almost. And we agreed amongst everyone that we considered primary prevention really important. And so we wanted to touch on it a bit, but this was also around secondary prevention and, you know, how do we stop it happening again? So the first thing of return to sport is you don't want it to happen again. So we wanted to cover it. And that was where we said, you know, in terms of screening, at that point where you've had a shoulder injury, you probably are going to need to be screened more often. And that was really the message we were trying to get across. We just don't we can't say, you should do this every 3 days or you should do this every 3 months or something, because it really depends on what sport it is, how much shoulder demand there is, and also on the resources of the team and how many people they have. If you're, I don't know, if you're playing in the NHL, you've probably got like a ton of backroom staff who are there to help to screen and to monitor these things, data scientists and all that. Whereas if you're playing on a Sunday morning and you've hurt your shoulder, you might just have like a mate who can watch how many times you do something. And we wanted to sort of like make sure that there was a bit of nuance within that, and that people weren't necessarily expected to do this like all the time if they didn't have the ability to do it, and that it was seen as a good thing to do potentially after an injury, but that was not like an expectation that we wanted to lay at everyone's door.
So what Paul just said about primary and secondary prevention is really a point that the team around Merete and Stieg and Martin wanted to point out, is that we should create a culture around risk management and a culture around primary prevention, for example, with implementing shoulder exercises that potentially prevent from injury, that also the athletes get more into I should take care of myself and learn how to deal with pain, with problems, etc. But also like that culture is really important, that there is a bit of a shift towards prevention.
And just a comment as well, you used risk management there, Ariane, and we were quite purposeful to try and use risk management as the term where we could, because we know that we can't always prevent all of shoulder injuries, particularly in contact sports where there's that element of like the unknown. And therefore we said, this is what we're doing to try and reduce that risk of recurrence. But we didn't want to use the word prevent where we, and give that expectation that we were going to stop it from happening completely, because we know we can never say that.
Yeah, and I think that's why it's a nice title, really, and I obviously understand the arguments behind using injury prevention or not, but, I felt you justified it really nicely within the paper, and also that division between primary and secondary there, prevention, whatever we want to call it, was really useful. And I'm sure people like Martin on board, who've gone through these large cohort studies and have embedded themselves in some big projects with, handball. And I've had a chance to speak with Martin and Stig about those things. Mm-hmm. Essentially, that cultural aspect of delivery of these programs and getting buy-in to these processes is a really important part. And it's great that you two, point that out. Let's move away from the injury prevention topic before we get too into that discussion, and let's move towards another one that causes probably a bit of disagreement and some language differences. But we're talking about managing shoulder-specific load in athletes, and I want to be clear here. I really again enjoyed this because I've talked with a few people about this. Load management in itself is useless when it comes to looking at specific shoulder, loads, and especially if thinking about collisions and contact sports, but also really important around, throwing shoulders and overhead athletes. So we know that quantifying internal load is context specific as well. Depends on sport, depends on all those other factors. But you mentioned the kind of use of a shoulder specific RPE, which seems like a really good generic option. Whether you're in the park with your mate or whether you're in an NHL team, you can use something that's going to be, comparable across a number of domains. So can you just give our listeners a little bit of a kind of example, maybe, of how you'd apply that in the sort of real world setting?
Yeah, the rate of perceived exertion, RPE, is one of very good and simple way of exploring how an athlete responds to the training as well as to the sport or the game, actually. And you can ask your athlete on a scale from 0 to 10, how hard was this last training on your shoulder? Or how hard was this game on your shoulder? And a suggestion is also to start early, also with youth athletes, so they get a sense and a feel for themselves, for their shoulder, for their exertion, but rather ask youth athletes maybe once weekly, because they might be overwhelmed by being asked every day. So the suggestion is rather ask weekly, but at least weekly for all athletes on all participation level is what a consensus was reached in our group, for example. And rate of perceived exertion is yet not validated for shoulder. Like, we don't know yet if we really get that construct by asking this question. And literature suggests to also include a fatigue question, like how fatigued is your shoulder, when asking exertion as well, because what you want to measure is your discomfort, your heaviness, and your fatigue of the shoulder, or also your mental state. You can also ask how stressed do you feel, how mentally loaded, and this is also very, very important. And it is one of the possibilities to detect internal load. And one question of our Delphi round 1, I think it was is internal load monitoring more important than external load monitoring? And there was no consensus, not even a disagreement. So people really have it varies so much across experts.
Yeah, I think one of the reasons for that as well is that we as clinicians obviously like that objective external load, because we can really count that fairly well from observation or from GPS or whatever we're going to use. And it's having the ability to tie the two together, which is where we've got that gap. And Ariane mentioned that it's good to get people into it at an earlier stage. So I think if you get younger age groups used to measuring the actual fatigue or the experience of feeling like tired in their shoulder early on, then they kind of know what it is when they then start to get into those more advanced age groups where that becomes more important to monitor those things. And post injury, it's even more important for them to do it and to do it truthfully, because we know that athletes, when they want to play, they might not always tell us what the truth. They might be like, oh, it's fine, it's a 1 out of 10. So we want them to be really truthful with us, because the key thing is them understanding that could actually be an indicator that injury is getting worse again, and taking a bit of time out now might obviously lead to them being much better a week, 2 weeks, 3 weeks down the line. And we know that a lot of professional teams have these easy capture systems now where they come in after a session, they get asked to rate on their iPad or whatever, score out of 10. And it's just a simple way of them being able to capture it easily and say, today it was a 5, today it was a 6. And if you're the data scientist or the physio or the whoever it is who's looking at this when they come in, you can then correlate that score against the external measures that you've captured and then see if they compare as well. So if the player's telling you that actually, my score today was a lot higher in terms of exertion, but you've given them the same amount of external load across the session, then you can be like, well, actually, is there something going on there? And that might prompt you as the clinician to go and have another discussion with them as well around, was that actually, because there's something else going on? Do we need to do an assessment? And that might be the little red flag that actually makes you take them aside as well and say, do we need to investigate this? Because there's a bit of a difference between what you're telling us is going on, what you're feeling, and what we're seeing in terms of the actual output that you're given. And it's more of like an early warning system as much as anything as to whether the recovery is going well or whether training is actually overloading them as well, from a primary prevention perspective.
Yeah, I mean, from a personal level, I feel like it's really important to distinguish between what's going on in terms of your overall fatigue level and mental health status, and your readiness essentially to perform as an athlete, and then your shoulder specific kind of local questions. So, you may see a point where you've got, global fatigue and shoulder fatigue, or you may see a point where, everything else is fresh, but the shoulder specifically is bearing the brunt of whatever's going on. And that is a different, that causes a different set of circumstances, different set of conversations within the performance team or within whoever the support network is, to try and deal with that in a different way. So I really like the distinction. I think, where the research is going with that in terms of validation, I personally don't think I need to validate something like that to make it really useful in my daily practice. I just get on with it and start putting it out there, and hopefully a group like yours or a research community will research it in the background as we gain daily, great information on shoulders.
Yeah, 100%. We know that sometimes research has to catch up with practice if there's an advantage there.
So the third section of the paper is around these kind of key principles for quality rehabilitation. And one of the consensus points that you draw out in there is that tissue-specific involvement may be considered, but the pathoanatomic diagnosis should not drive shoulder rehabilitation. Now, it's a great statement. Can you explain this consensus point?
This was indeed a very interesting time in our in-person meeting in Bern. We had long discussions, and it was not too easy to formulate this statement as well. We ended up with the consensus mainly as rehabilitation should be guided by irritability. And irritability in that sense is how much pain do you have? Do you have night pain? And how high is your level of disability? And you differentiate between high irritability or low irritability. So lower irritability is no night pain, for example, or pain that decreases pretty quickly, more mechanical pain. But we also discussed, for example, if you have an acute slap lesion, yes, do not load your biceps strongly. Like, do respect that there might be a tissue that is ruptured, and you need to let the body heal. But also, you should, in terms of tissue change, you should not take tissue change as a marker for your pain level, or your pain level as a marker for your tissue change.
I was just going to say as well, I think from the pathoanatomic perspective, we also know that the way that we image things, we're often going to see like these issues if we image them. And we knew that they don't always correlate with the symptoms that we're going to see. Therefore, we said that we can't allow that to drive the rehabilitation. We need to basically design the rehabilitation off of the deficits that we're observing at the time and what the patient is reporting, not necessarily driven off of what the diagnosis is specifically. So that sort of came down to that a little bit more, because we know that there's often athletes who are carrying injuries as well from previous, and that might be that does influence our decisions a little bit, but it really did depend on what they were presenting with at the time, and we didn't want the clinician to say, right, well, the person's being diagnosed with this, therefore we must treat just this. We need to look at it more as a holistic kind of thing and see what other deficits they've got going on, what issues they've got in their kinetic chain, which I think we're going to come on to in a minute, and then see about, like, can we actually resolve those and make sure that this isn't going to happen again? And it isn't always necessarily down to that specific diagnosis why they're getting pain, if that makes sense.
Exactly. And also, if you get a diagnosis, you as an athlete may incorporate this diagnosis, and I am the one with this, and that's not helpful for your progression back to performance. But also, really important is that we have those terms like GERD and ERG, and they are normal adaptations to the demand of the sports, especially in throwing athletes. You see also that you have a increase in retrotorsion of the humerus, and this is all good. We need that to be good in that sport. And if we, by coincidence, like if we have an athlete with shoulder pain and then we see structural changes in your either bone or in your soft tissue, then we relate that to each other. That's what we see with rotator cuff, especially with the rotator cuff, all the repairs that are going on, that we relate pain to those changes, and this is probably not going in a good direction. So we really wanted to emphasize the focus on how does the athlete move, how does he perform, how does he feel when doing this, and how ready is he, and how does he manage and learns to control. Because if you say, oh yeah, you shouldn't move into pain because you have this rotator cuff problem and tear, then the athlete is not in control of his body. He is worrying too much, and then he might not progress, or she. And so we need to focus on how does the athlete perform, how does he manage it, and load him progressively towards back to his level of sports. And that's really, really important, and that's what we try to focus here in this section.
Quality of movement over everything, is the move. That's not something that you can necessarily describe in a paper. It comes with experience and knowing the player as well, and knowing how they move normally. Passing the eye test, I think people call it, is like, are they back to their normal movement patterns, and can you see that? If you see someone every day in training, you kind of get used to the way they move, and if you can notice those small subtle differences often in where they're sort of moving slightly differently, and that's not something that we can necessarily put down in this, but that did come up, that the movement quality is returned to normal is one of the other things that you use almost as a decision-making marker from a coach's perspective, or the rehabilitation team's perspective.
Yeah, that's great. What we'll do for those of you who aren't up to speed on shoulder injuries, and obviously I encourage you to read the paper. But if there's some abbreviations that you're not aware of, we'll put those in the show notes at the end. So don't worry about those, the GERDs, the ERGs, and the TROMs and everything else there at the moment. We'll leave some links in the show notes.
One bridge that we can build here from rehabilitation back to injury risk management is that one of the risk factors for injuring the shoulder is a gradual onset injury, meaning there was pain before and then you have an injury. But the question about all the tissue as a marker for pain as a marker for tissue damage is what is gradual onset injury? That's where we start in a way, because if you have felt pain over a period of time, does this mean there is an injury, an underlying injury, or not? And that's also a very interesting point in the whole rehabilitation and prevention, and maybe a future direction, because how do we interpret pain? And I think that in different sports there is a different relation to pain. A swimmer might always feel a bit of pain and thinks, it's something normal, but in another sports player is really frustrated when feeling pain in the shoulder and can barely tolerate it. So this is really an interesting point in the whole in the whole topic of it. Yeah.
And I think that sort of hits on a little bit about the sort of psychological aspects of this rehabilitation process, how do we dress up the language we use, and how do we communicate what's going on to keep the athletes buy in and keep them on board, not medicalizing things, to a degree. So psychology is something that's, massively in the whole community at the moment is a big buzzword, but let's specifically try and bring it into kind of quality rehabilitation of shoulders. Can you sort of summarize where you feel psychology fits into the management of shoulder injury in sport? Huge topic, but I'm asking you to do it in a very short space of time.
I think in terms of not necessarily specifically in the shoulder, I think we should say that psychology is just across the return sport continuum generally. If we go into what we discussed in the Delphi, it was quite clear that we had 6 things that clinicians needed to consider when they're returning someone to sport. And they were the 6 categories that we put in that final section. So we had the range of motion, it was strength, power, rate of force development. Ariane, help me out. I'm trying to remember what the brain's going dead.
Wait
a minute.
Second.
Yeah.
Kinetic chain, psychology
chain.
and readiness, and sport specific.
Yeah, and sport specific demands. But yeah, so psychological readiness came up as like being one of those 6 key fundamentals. And I think it was around the player feeling ready alongside all of those other metrics that we have. So, if they've got the range of motion, if they've got the power back, if they're passing their return to sport test battery that we've decided is appropriate for that sport, and they feel ready, that was the other thing that was key. And that feeling is important, because if they pass all these external measures that we've got, but they're telling us something's still wrong, then we'd be silly to like throw them back in, because that generally means something is wrong. We just haven't found it, or we need to find some way of like measuring what that is. And even if it is like if it is a psychological thing, then we need to do something to address that. We can't just throw them back into like the full demand of the sport and expect that they're going to flourish, because their performance is going to be off, even if they're not injured. Like from our perspective, if they're not feeling right, then they're not going to hit their peak. So it's not going to work.
Yeah, and I think it sort of works sometimes the other way around as well. Athletes will have bad experiences, past experience, which can influence their psychology around return. So everything can look great. All the objective data can look, pretty good to you as a performance team, but they still don't feel right. And that's based on the kind of historical experience. And sometimes using that objective data and, look, you're great in this. You're way better than you were pre-injury. You're much better on this. Everything else is looking great. And you cope with that session really well, much better than you did. The technical coach thinks you're going well. Sometimes that can be the thing that actually helps them, helps the psychological piece of the puzzle as one of those kind of 6 domains. So yeah, I hugely value psychology in there, and the way you guys have given some examples at the end is really useful.
Yeah, it was clear that we knew we needed to measure it, and it needed to be something that we took account of before we put an athlete back into full training or match play. And therefore that was why it came across in the paper. But as you just outlined as well, it's really also a useful thing for us as clinicians, because that's when we can use our soft skills. Because if all of those other markers are moving in the right direction, but the athlete themselves is not confident or, a little bit concerned, that might have been their first ever injury, and they might be worried about it happening again. It gives us that signpost that as the therapist, we need to do a bit more work with them on that side. And that might be around giving them that extra reassurance, confidence, so that then when we take a CERSI or, whatever other measure of psychological readiness we're going to take, that hopefully that's going to have increased. And then we can be like, oh, look, yeah, they're improving, they're looking more ready to go back. and that actually helps us to be confident in our interventions also being positive, because that's one thing I think we actually do a lot of as therapists, but we don't often account for it, is a lot of that educational and support side, which we're really good at, and we don't sort of measure it. We just go, oh, we talked someone through this, we gave them reassurance, and the person walks away and they feel loads better after that. But we just sort of put that to the side and we worry about all these other problems and other outcome measures like that are more objective. But that actually in itself is super important, and we wanted to highlight that in the paper.
Yeah, and we also started with in the rehabilitation section at the in-person meeting about talking about building the resilient athlete. And we were talking about like that's also a psychological part, like how resilient are you, and the temporary side of it as well. Is it pre-season, mid-season, after injury, before injury? But resilience is a huge word and left open for interpretation. So we also decided to take it away again. But it is a bit about your resilience, your inner, your outer resilience. And definitely also about control. And that's, and again, the bridge back to your understanding of your injury, of your pain. Because if you know how you're reacting or how your body reacts on certain loads and certain movements, what is your capacity, then you learn to control those pain levels in a different way. And I think that's one of a key point as well in your rehabilitation. If you learn how your body answers to certain loads, then you learn, then you get better. You feel more ready to go back to your training or sport or performance, wherever you are. And that's really important. Also, what Paul mentioned, our position as rehabilitation specialists and physiotherapists, how we educate in terms of pain neurophysiology. That's a very important topic here, which we could just touch a little bit on, but this is not covered in total in this paper.
Okay, so in the paper you had like 7 key principles, and key principle 3 was do address the scapula in rehabilitation, but do not screen for dyskinesis. And I think, Ariane, at the start you sort of mentioned this buzz topic that seems to create, I mean, there's a whole summit written up about this particular area. So let's not write up another summit, but, essentially I want to explore a little bit about what was said around how to address the scapula in rehabilitation from a panel of experts that you were in and around. As you know, it's a really interesting discussion, I'm sure.
I wanted to just highlight, so there was definitely a split in the groups of experts on this one. So there was a lot of people who do really focus on the scapula and try and address it as part of the rehabilitation. And then there was a group who were just like, you don't need to worry about it. And it's something that is just a natural part of the movement pattern of the sport, or, as Ariane said earlier, a physiological adaptation to the demands of that sport, such as in swimmers, or often you see it in like tennis players, except other overhead athletes. But the idea around us saying not screen for it was for that very reason, that we considered it a physiological adaptation. But if you see it and you think that actually, you can improve performance by addressing any dyskinesis or poor movement across the kinetic chain, we sort of said you have to think about it in terms of being part of the kinetic chain, then you should include it as part of the rehabilitation process. So just to give an example, if you've got somebody who comes in and their right side is worse in terms of the left, like looking at the right versus the left, and we want to do a rehabilitation program, and we want to address serratus and all of those other scapular stabilizers, then we do need to like include that as part of the rehabilitation program, but not necessarily worry about it if the athlete's performing well and, you know, they're not reporting any problems. You know, we don't want to make a problem by screening for it and say, oh, actually, we've just seen this, you know, you need to come in and do all this work with us, and give them that. Again, it comes back to that psychological piece, give them that thing, that worry that there's actually a problem with their body when they're performing at their best. You know, just if there's no problems, don't worry about it. Leave it alone.
Yeah, and also I think at the in-person meeting, we ended up deciding that the scapula is not a part of the kinetic chain; it's the shoulder, and you should not. And also, we had a consensus about kinetic chain timing. When do you start building up your kinetic chain? And we ended up finding answers around it doesn't matter. Do it simultaneously. Check with your athlete. How does he show, like, how is his kinetic chain? How is the lower extremity and the trunk and everything? How does he perform? And then decide upon your athlete, upon his rehab, where should you start with different exercises. But with the scapula, you cannot isolate the scapula from the cuff or the cuff from the scapula. It is not possible. And so with every scapular program that you start, you also address the cuff and the deltoid. So you cannot think of it as two different sections of your body. And we had a lot of, as Paul said, like it was actually quite funny because the whole scapular specific questions in round one, we had like 5 questions, and all of them were not reaching consensus. I have one example. Scapular rehabilitation should only commence once a stable proximal base is established. So there was no consensus, not even disagreement. Or exercises should activate different scapulothoracic muscles, and there was no consensus.
Yeah, and I actually think that's where a lot of the value comes in doing the consensus process. Is we were able to draw out where those disagreements were, and as I said at the start, that was where we were then able to sort of try and tease apart in the room why that disagreement exists. And it's not often that people fundamentally disagree. They just have different takes on the same thing. Yeah. And it's not necessarily that we don't address a problem if, say, like the dyskinesis resulted from an injury. You know, everyone agreed that you would try and rehabilitate it. It's that you don't consider that in isolation, and that we don't consider the scapula in isolation. And so I think a lot of the time it's just the language and the interpretation around the language that gets a bit of it into holes, like where people sort of say, oh no, I'm on this side or the other. But I think hopefully we did a reasonable job of trying to present that to everyone in the paper and giving them a way forwards.
Yeah, you can get lost in translation. I try not to talk about scapular dyskinesis. You know, I like to talk about load transfer and like efficient movement and you know, energy leaks essentially. So
yeah,
any way along that from base of support to point of delivery or point of impact is a really important component. And whether you call that kinetic chain or not, it's load transfer essentially.
Yeah, that's the same. And I had a water polo player come in recently, actually, and I had that exact conversation with him around his shoulder was actually super strong and his scapula was okay, but he was really weak across his like abdominal region. And when you got him to do any like high plank or roof rotation or anything, and although it's hard to say that's a causal link to a shoulder injury, it improved. His shoulder pain and everything improved once we'd addressed it. And it was like, okay, well, you can't consider the shoulder or anything in isolation. There's always going to be, you know, the potential that a weakness somewhere else is putting more strain on the shoulder for them to perform at a high level. And therefore, if you don't address those underlying factors, you're never going to get that person back to the position where they can perform at their best. So that was like a lot of the discussion was around nothing. Really, you don't focus on anything in isolation. You have to consider the body as a whole, and if there's a problem somewhere, it's either going to cause strain somewhere else, or you're going to get an injury in that place where it's weak. And that's just comes back to like fundamental, like being a good clinician and not just like saying, oh, the pain's in the elbow, I'm just going to treat the elbow. You know, you look at the shoulder, you look at the wrist, you look at the neck, you look at the thoracic, and then if there's deficits there, then we have to plan those, like to address those in our rehabilitation process.
That's all we've got time for today. There's going to be a part 2, so stay tuned for that. If you'd like to follow today's guests, you can find them on Twitter and Instagram, and we'll give you the links to that. You've been listening to Informed Performance, and we hope you enjoyed today's episode. You can find us online at informedperformance.com or on social at Informed Performance for Instagram or at InformedPod on Twitter. Thanks for listening.
Just before you, the listeners, disappear, Ben, via Athletic Shoulder, has released an Athletic Shoulder Level 1 course, bringing together 20 plus years of experience around shoulder health, performance and rehab. If you purchase now, you will save 33%, costing you only £199 instead of £299. You can sign up for this offer on his athleticshoulder.com website to do so.